that we're here as academics, as researchers, to serve our participants, and we must never forget the person amongst the research process. And I hope you've already seen that patient and public involvement is a key value of this conference. I came into research because a care coordinator had seen a flyer, and there were some researchers, they were looking for service users and carers to train in research methods so that hopefully they might join their research team. And I took this flyer home, I showed it to my wife, we were like, could anything come of this? Probably not. But they're paying you to attend. So I was like, right, let's do it. And then as a result of that training, I then joined the research team. So some researchers, they took a risk and they believed in me. And I think it takes someone special to believe in you, but it takes someone extra special to help you believe in yourself. And that's really what the Equipped Care Planning team did. They helped me to believe in myself. And that's what good patient and public involvement can do. Really help us see that our lived experience is vital to the research process. And that patient and public involvement is so crucial. And this conference has a really special place in my heart, and I'm sure in yours too. A place that's really supportive, a place that's really inspiring, a place that's really nurturing, whatever your background. And I'm honoured to be on the committee and to be chairing the second day of our time together. Just in terms of some housekeeping, so we're not expecting a fire alarm today, so if it does go off, please leave in an orderly fashion. There is a prayer room available upstairs if you would like to use that at any point during the day, so that's available upstairs. I've been asked to remind concurrent chairs, if you're chairing a concurrent session, could you please keep to time so that the conference can run smoothly again today. Twitter, so again we're on the hashtag MHNR2019, MHNR2019. So please do tweet throughout the conference. If you're looking down at your phone, we won't mind. We know you're still engaging, that's okay. Posters for day 2 are now on display, so please make sure that you've put in your votes for your best poster of the conference. Details of how to do that are displayed on the poster boards, and we'll have our kind of informal awards ceremony at the end of our time together. We'll be presenting best poster and also best concurrent session as well. So I hope you're looking forward to day 2 as much as I am. So our first speaker is Departmental Chair, Georgetown University School of Nursing and Health Studies, past President of the International Society of Psychiatric-Mental Health Nurses in the US, Dr. Edilma Yearwood, speaking on examining the evidence on mental health literacy and stigma reduction in low and middle income countries. Please welcome Dr. Edilma Yearwood.
Good morning. There's absolutely no pressure. I've been told you're going to knock it out the ballpark, you're going to represent us well, so there's absolutely no pressure. I didn't sleep at all last night, okay? I just want to thank Ben and the committee for honoring me in asking me to do this keynote. And I want to give you a little bit of context. As Anthony said, I am the chair of Department of Professional Nursing Practice at Georgetown University, but I'm also representing International Society of Psychiatric-Mental Health Nurses. And also more recently, I have become a member of the board of the Global Alliance for Behavioral Health and Social Justice. And so I just want to give them a shout out also. And so when I was thinking about what I wanted to present today, I was thinking about my students. So I teach psych mental health nursing to pre-licensure undergraduate students. And one of the things I've been sort of looking at is their comfort level has increased with the whole topic of mental health and going into their psych mental health clinical. And so I was trying to think about what might be causing that increased comfort. Because when they come to me, one of the first questions I ask them as a group is, tell me how you feel you're going to do with this clinical rotation. And so, you know, fear, this is foreign, I'm petrified, here's what my prior experience with this population has been. So that was sort of in my head. And so I wanted to do something that sort of was an extension of some of those experiences. So basically, I decided to have us talk about stigma and mental health literacy. So in looking at the literature, these two concepts are absolutely tied together. And so in thinking of my students who came to me with a lot of preconceived notion about this population and a very high stigma against the population, but being exposed to the content, being exposed to the clinical arena, and spending time in their psych rotation, you could definitely see by week 3, their comfort level was increasing and their conversation, their language that they were using about the population was changing. So it made me think that maybe the piece that we have to pay attention to is how to increase mental health literacy, right, in order to affect stigma. So of course that's, the literature is very laden with that information. So our objectives are to discuss the various types of stigma within the context of culture and community, and I'm going to highlight a few things in the slides that are coming up. I think the issue of culture is something we need to really be mindful of, and we also need to be very mindful of the issue of community, because I think we have to make a change in those places. And then critique current anti-stigma campaigns and activities that are found in low and middle income countries. And then to demonstrate an understanding of the relationship between mental health literacy, stigma, and treatment engagement. So because my style in class is usually to have you do the work, you are going to be doing some work shortly, okay? So just be ready. So in listening to our presenters yesterday, I went back and added this slide because one of the threads I was hearing yesterday is, I felt I was hearing a lot of, what do we do? This is a huge problem. These are huge, big issues, and how do we tackle them? So I wanted to sort of have that as the beginning frame. We are creative people. We are bright people, and when we target something that we want to change or to work on, we can usually figure out the solution. So that's going to be your job a little bit later on. So no pressure on you either. So how do we tackle big, difficult, intractable problems? So increasing mental health literacy in low and middle income countries is a big, intractable problem. We have so many barriers, so we're going to talk a little bit about those barriers. And then, coming from a Jesuit Catholic university where I've been teaching now for 17 years, I'm really, really grounded in what is our moral imperative. Who are we responsible for besides ourselves, right? And it's my personal belief that we're responsible for each other. And so in this space of mental health literacy, in this space of stigma, how are we going to move forward to make a change? And what is our individual and collective responsibility for our fellow human beings? So I want you to think about that a little as we proceed. And in hearing some of the different experiences in the room, I just wanted us to sort of be clear on what are some of the drivers, but also that we have similar definitions. So I'll share some of those with you. So as you've heard in the last day or so, mental health disorders impact approximately 1/4 of our world population. So this is a very significant issue that we're dealing with. What do people know about mental health? What do people know about well-being? What do people know about how to manage themselves? Depression, anxiety, suicide, and substance abuse are the most prevalent areas of concern within our field. Approximately 450 million people are impacted by mental health challenges. And I'm going to try to remember that I prefer the word challenges rather than disorder, because I think we're all challenged by a variety of different things, and it decreases the stigma if we use the word challenge as opposed to disorder. When we look at our sisters and brothers in poor, low, and middle income countries, they are challenged by the lack of resources. And when we talk about resources, we're not just talking about structures, we're not just talking about financial, but we're talking about people. So who is there to deliver treatment, right, in those environments? And someone mentioned yesterday the whole issue of Maslow's hierarchy of needs. And we have always, as a society, functioned basically looking at meeting those needs that are the most important, which is basically food, shelter, housing. I want to challenge us to think that absolutely those are critical issues, but we also have to think about well-being as a significant issue that we have to pay attention to. Now, most of us who live in high-income countries, I think, sort of get that, but it is not a priority in countries where there are less resources and less people to manage challenges that folks are experiencing. So we start with health literacy. And so this is the definition of health literacy by the World Health Organization in 1998. So they basically said that health literacy is cognitive and social skills that determine the motivation and ability of individuals to gain access to understand, and to use information in order to promote and maintain their health, or good health. So we'll start with health literacy. But then if we sort of look at the newer language and descriptions that relate specifically to mental health literacy, it's broader. So it's basically, how do we help others, and ourselves actually, understand psychiatric disorders or mental disorders, the treatment options that exist in order to get someone to do something. So the important thing now is the action. So having the understanding of the mental health challenges or disorders that people face, you want to increase what they know in order for them to do something, right? To change some belief, perhaps, or to act in a different way. Mental health literacy also pertains to obtaining and maintaining positive mental health. So how do we prevent a relapse? How do we prevent a more chronic state long term? So prevention is part of this picture of mental health literacy. How do we understand our risk factors? And how do we understand those early warning signs, the early symptoms? What do we do when we experience those early symptoms? Do we sort of isolate, ignore, things get worse, or are we proactive and take some control over preventing things from getting worse? Mental health literacy also involves a level of motivation. You have to do something. You have to be motivated not to go down that slippery slope. So how does that look? What does that look like, and how does that work? And how is the individual engaged in his or her own self-management strategies? Now, if all of these sort of line up, and the individual has high mental health literacy, there's a different understanding of these set of symptoms, disorders, challenges. So hopefully decreasing the stigma or those biases against or discrimination against what this thing is, right? And my favorite part of this whole concept or this thinking is about personal agency. If we give people enough information, we are now saying you have control, you have the ability to make decisions for yourself. And I think that that's the bottom line. We may not agree with the decision, we might want a different decision, but the bottom line is everyone has a right to make a decision as to whether or not they're going to engage in treatment or not engage in treatment. But we've given them, or we've provided the arena for them to have the information so that they can have their own agency moving forward. So why is this important? Mental health literacy, if we increase mental health literacy, we can deal with some of the inequities that exist. If we increase mental health literacy, we can decrease poor health outcomes. We might affect chronicity. Now, we talked yesterday about things being on a continuum, so perhaps we won't have people who are constantly dealing with poorer outcomes if we can increase their mental health literacy. We can decrease healthcare costs. We can affect or impact the level of stigma that we're dealing with now in our society. If we increase mental health literacy, we can hopefully decrease human rights violations. We can impact the mortality and morbidity that are associated with mental health disorders. We can increase quality of life, make the quality of the individual's life better. Social isolation can be decreased if we increase mental health literacy. And we can avoid compounding those other comorbid conditions that we see with our population. Now, theoretical framework, those of us who are researchers and clinicians and educators love theoretical frameworks. So Bronfenbrenner, our go-to person, who looks at socio-ecological perspectives, has 5 layers for us to look at. And so this is why when we're looking at mental health literacy and stigma, it is such a hard problem because it is very complex. It is not a straight path to anything. It's a path that has very many offshoots, as it were, and distractions, because we have to pay attention to those distractions, okay? Those are important things. So basically with Bronfenbrenner, as many of you know, he looked at microsystem, which is the immediate environment that we live in, or the individual exists in. He also talked about the mesosystem, and that's how we're connected with other people. So it could be school, it could be extended family members. Exosystem, which is our indirect environment. So do your parents have jobs to help you access treatment, right? Do they get insurance to help you maintain treatment resources? He also looked at the macro system, and for me, I'm always looking at culture and social systems. That's the way sort of my brain is wired. So that's really, really critical and important. So if we're going to intervene to increase mental health literacy and decrease stigma, we have to be mindful of all these pieces, right? So the social and cultural perspective is important. And then the last layer of this is chronosystem, which is over time. So are there changes over time? And one of the speakers yesterday mentioned that in 35 years of our dinner speaker last night, she was mentioning that she's seen some changes in the 35 years of her work in mental health. And so that's a good thing. We're going in the right direction. Most of us who are probably adult ADHD kids want it to move faster. But we have to sort of slow it down and be patient and observe the fact that there's so many pieces to this that are important for us to sort of navigate. This is just kind of a busy slide, but in order to improve mental health literacy, we have to do multiple things. It's not going to be one approach. We have to understand that we have to do many different things to have a better outcome and to increase mental health literacy and decrease stigma. We have to increase our awareness campaigns. And when does that start? Well, my recommendation as a child adolescent clinical specialist is we need to start with kids. We have to start with schools and with children early on. You know, how do we help them understand that depression is not an unusual thing, and that this is what it looks like, and here are things or strategies that you can do to manage that. We need to do education. We have to have workshops, exposure, development across a variety of different constituents, not just our consumers, but we also have to educate ourselves and our colleagues. We have to do this in primary care, we have to do this in acute care, in our communities. Training and skill development, one of the biggest barriers, I think, for us who work in this field and want to work more in low and middle income countries is the whole issue of the lack of resources, financial resources, and the fact that this is not a priority area in most of these countries. So is there budget allocated to do some of this work? And the answer usually is no. Well, how do we disseminate information? So once we have a campaign or a strategy to get information out, how is it that we best disseminate that information so that it can reach a larger number of individuals? And then one of the things I want you to really think about is that one of the underutilized resources, I think, in low and middle income countries are our faith partners, our faith tradition, our healers, our traditional healers. How do we engage them in a different way to help us with some of the work? Those are the credible people on the ground in many, many communities. And so I don't think as researchers have intentionally engaged them in a way that we really, really should. One of the things, and I'll share it with you when we look at some of the research that's been done, everyone's basically saying the same thing. We do short-term fixes. We do short-term research. We go in, we stay for a year, we get out, we collect data, we have wonderful data about what works for the short term. Well, we can't do that anymore. I mean, we've already done that. We need to know how these interventions, what these interventions look like over the long haul. And there are tweaks in things that we're doing that we have to now put in place to help sustain some of the work around stigma. Here I also put, we have to target schools, as I said before, but the entire breadth of our school system. We want to start with young kids, but we also have an opportunity with college-age kids, university individuals, to do some of this work. They could also be our boots on the ground to help decrease stigma and to increase mental health literacy. And then several people have mentioned in the last day or so about the use of social media, and so that's another piece. So this is a very complex set of problems when we're talking about stigma. It's a complex set of issues when we're talking about increasing mental health literacy, but we have to use a complex or multiple strategies. Not one thing will work. We have to really attack this issue from multiple perspectives. And so later on, you're going to figure that out because I'm going to give you a job to do. Okay? So these are interrelated concepts. So stigma, and many of you, of course, are familiar with Goffman, who really started this work way back when, I think in the 80s or something. Stigma is a perceived negative attribute that causes someone to devalue or think less of the whole person. So basically, stigma is shrouded in negative, and so as a mental health professional, my personal concern is when the individual begins to self-stigmatize. I mean, it's bad enough that society or other groups stigmatize the individual, but I think our work becomes much, much more difficult when that becomes internalized. And so these are different types of stigma: self-internalized stigma, perceived or anticipated stigma. So if you're an individual who's been stigmatized by a system, let's say the clinic, whenever you go, you have a lot of difficulty navigating a very simple process in a clinic, and you're getting a lot of attitude or negative comments by the people who work there. you might avoid that place because you're perceiving that it's going to happen to you again on the next visit. You anticipate it happening. Stigma can also be by the group. So there might be individuals or communities that associate the family with somebody who has a family member who has a mental health challenge, so they avoid or stigmatize the entire group. So that's another type of stigma. Public or community stigma, we already know this, that the mentally ill as a group are stigmatized profoundly by many of our communities that we navigate or live in. Structural, there are policy issues that prevent people who have challenges from navigating or getting the appropriate services that they need or the appropriate community support to be able to be more successful. And then the last one here is social, cultural, gender, age, religious is another type of stigma that can occur. So one of the first individuals I looked at when I was getting this talk together is Pesco Solido and Martin, and they're at Indiana University, and this was a piece they wrote in 2015, when they looked at stigmatization, and they looked at it as a social process, and it's about power, and it's about stratification. When you stigmatize individuals or groups, you are in essence exerting power over them by this process. And stigma also occurs in the context of social relationships that either endorse the social distance, so you set up a system where the relationships isolate, the lack of relationships can isolate the individual or the group. Culture and the cultural experience can also reinforce some of the stigma, and stigma can exist as a spectrum or in a continuum. So those are factors that they talked about with this stigma complex. This is a very busy slide, but this is sort of the way my brain goes sometimes. And I loved it when I came across it. It's by Stengel and al., and this is a 2019 publication that I found this in. Basically, what they did is they tried to lay out how complicated this is. And going back to what I said earlier, in order for us to make to impact this issue of stigma and to impact mental health literacy in a positive way, we cannot look at just one piece of this. We have to think broadly, and we have to attack this process from a variety of different strategies. So it's about the population, it's about the context of the population, it's about individual people within the population, it's about the provider in the population, it's about prior experiences, us as researchers understanding what the prior experiences have been. It's about those social structures, how do we engage with those social structures, schools, NGOs, the policymakers. For those of you, I don't know if any of you have done work in low or middle income countries, but the people who tend to have a lot of the power are people like the ministers of health. So how do we as researchers understand that as we engage in a community, we have to really work with a variety of different players within that community. And I think one of the significant players is the Ministry of Health. They're the ones who have some level of power, but they also have access to resources. So just sort of to think about that. So this is a wonderful framework for anyone who wants to do research in this area, because it really encompasses some of the different things that you as a researcher is going to have to think about, and how do you tackle these various pieces, knowing that you will not be very successful if you don't tackle the various pieces. This really lays out how complicated I think this whole process is. And so just to summarize what we just said, so when we work in low and middle income countries, we're dealing with issues of poverty, lack of resources, low literacy, cultural barriers, challenges to human rights or violations of human rights, and lack of policies, right? So those are some of the drivers that maintain stigma in these communities, but also these are the things we have to tackle in order to increase mental health literacy. So in looking at some of the evidence, Andrew's going to keep me on time because I'm going to try to end in 35 minutes so that we can have an assignment for this side of the room and an assignment for that side of the room that you're going to work on and then give us back some information. So Logan Nathan and Carter, in looking at some of the evidence in this area, they looked at improving mental health literacy in various settings, and they were really more focused on low middle income countries. And they did a systematic review looking at the research from 1980 to 2002. And what they found was that in most of the research that was done during that time, looking specifically at mental health literacy, is that segmented approaches work well, right? So doing work with individual constituents seem to work well compared to working with the entire community. And I put here in bold because I think you really need to do both. All right, so that's my bias coming in right here. They felt that the targeted or segmented approach was more effective. It was cost effective. It allowed for more interaction with the community to get feedback, to adapt and unpack any cultural beliefs and misconceptions. And that the messages needed to be targeted to those segmented groups. All right, so that's when they did that review. That seemed to be what they found. Rao et al., another 2019, did another systematic review of research on multi-level stigma reduction interventions, and they looked at 24 studies from low, middle, and high-income countries. Right. 11 of the studies were from low, middle-income countries, but it focused mostly on HIV, epilepsy, leprosy, and just several on mental health. So it was basically saying we don't have enough really good studies specific to mental health. What they found was education was the most common stigma reduction method, right? So it made me remember how I see my students. The more they know, the more exposure, the more social contact with folks who are dealing with their mental health challenges, the more I was seeing a difference in their attitude and their behavior and their comfort level. So that's important. So that educational intervention, I think, is something we absolutely cannot avoid, right? But they were saying that the education plus the social, the contact was important. So it's doing more than one thing. We have to sort of go outside the box and introduce several different interventions, as it were. Another set of researchers, Tillahone et al., examined the stigma experiences in children with developmental disorders, caregivers of children with developmental disorders. And so these were contexts where there's a high level of stigma against these kids and their parents. The parents believed very strongly that there was a cure to their kids' developmental challenges. But what the findings ultimately were that we need to look at the cultural context, but we also need to try to be true to some of those biomedical perspectives. So it's for those of us who are researchers and clinicians, it's not that we need to give up some of what's driving our understanding of this phenomena, but we also need to be very, very culturally aware and sensitive to the fact that a blending of these two perspectives probably is the right way forward. Another study was from Kemp et al. This is another recent 2019 publication. They looked at 35 studies, and what they found was the research that they were looking at was very poorly done. No conceptual framework, very limited descriptions, poor sustainability, limited studies on mental health. They only found 3 of the 35 studies that they looked at. And so basically recommended that we have to increase rigor of our research to include theoretical frameworks, to have a better description of our method, our measures, and to develop research that's going to be generalizable to other populations. And that may be a question those of us who are qualitative researchers might have to have sitting out here for a moment. And then what they also said was long-term. Are we designing studies that give us a long-term perspective and give us information about the effectiveness of our interventions long-term? So that's something we have to pay attention to. Mascayano and colleagues also did an opinion piece where they looked at a variety of different studies, and they were looking at addressing stigma relating to mental illness in low middle income countries also. They looked at anti-stigma campaigns in India, Colombia, Nigeria, Ethiopia, Uganda, South Africa, and Iraq, and found that there were very little studies that were culturally informed. And so we see the theme going through. We have to pay attention to the cultural perspective, the setting, the environment. And also found that there was a lack of attention to mental health services, to stigma reduction campaigns, and that mental health literacy was very, very poor in low and middle income countries. So there's a lack of rigorous methodologies, lack of evaluation, poor definition of terms, i.e. stigma. How exactly are we measuring stigma? So that was part of what they were finding. And so they were recommending that we have to do better with our terminology, our measurements, but we also have to be inclusive of the perspective of culture in some of our research. So Haim et al., another study that was done, this was done last year, the findings were reported last year, looked at 18 studies, and they looked at prior systematic reviews, and then they included a short update on reviews, and they looked at studies from 11 different countries. And they looked at participants included as our nurses, practitioners, community mental health workers, and they basically looked at, what they found was that there's lack of standardization of designs, lack of standardization of procedures, analysis was shoddy, and that there was no explanation of how missing data was managed or handled in some of the studies that they reviewed. Basically recommending more rigorous trials, clearer measurements of concepts. How do the studies define stigma? How are they measuring stigma? And how are they including culture in the research design within the studies? So you're hearing a theme, all right? And so I'm gonna, Andrew, how am I doing with time? Oh, thank you. So basically, when I looked at this review, when I was looking at these reviews, everyone was basically saying the same thing. We don't have enough research focusing specifically on mental health literacy and stigma in low and middle income countries. The research that exists is faulty. A lot of the research is qualitative, so and the quantitative research that's being done is poorly designed. The quantitative research that's being done is not giving us information about the long-term effectiveness of the interventions, and the research that exists is not including enough of a cultural perspective. So for those of you in the room who are community-based participatory researchers, we know that in order for us to do good work in these environments, it's not okay for us to come in and impose our thinking. It's about, can we go in, stay for a while, be very open to hearing the perspective of the individuals we want to work with, have them help us design the studies, have them involved with the studies, teach, research, data collection, running focus groups or whatever, help them learn with us how this environment works, how we have to adapt to the environment so we can develop a better study that's going to give us good data from that specific environment. And have them endorse or challenge some of our findings, right? So I think that's going to be very important. So I'm going to move ahead because I really want to get you guys working a little bit. So for those of you who don't know that this exists, the World Health Organization has a health literacy toolkit for low and middle income countries. And basically they're saying exactly what I just said, that in order for us to do this work well and increase mental health literacy in more vulnerable populations, i.e. low middle income, we have to engage the community in a different way. We have to stay longer. We have to hear their perspective. We have to incorporate their perspective in our research design. We have to do a lot of education. What is mental health? What is well-being? We have to carry the message of anti-stigma ourselves so that we can help to model for those that we're working with. We have to work with the structures that exist in those communities, schools, ministers of health, NGOs, everybody, all those structures that have some control and power within the system. We have to educate them. We have to educate our primary care providers. As I said before, I think we have to start with children. It doesn't mean that we ignore adults or older adults. It means that I think if we have limited resources, where we put those limited resources, I think we can change perhaps the next generation and have them think differently and decrease their stigma against our population. Okay, I think that's where I want to stop. Okay, these are just a couple of folks that you guys have heard of. So Goffman, a big guru who wrote a lot on stigma. Lincoln Fallon, who have done a lot of work also on stigma. Jorm, Anthony Jorm out of Australia has done a lot of work with mental health literacy, and your own Thornycroft, stigma and discrimination. Those are some of the folks I've been reading about and reading their works. So I want you now to do some work, because we're going to take about 5 minutes each of the. So I don't know how you want to group yourself. I'm going to give this side of the room a question and this side a question. Group however you want to. So on this side, think about some of the definitions. Think about what you know from your own personal experience and your readings and your work. What would an effective approach be to increasing mental health literacy and decreasing stigma? What does that look like? I want you to go as outside the box as you possibly can. Get wild and crazy and pretend you had all the resources at your disposal to work on this, all right? There are no barriers at all. If you wanted to increase mental health literacy and decrease stigma in a low and middle income country, what would that look like, all right? This side of the room, I'm going to give you a little bit more difficult challenge. I want you to think about what the research is going to look like, all right? So these folks are on the ground, working with people, perhaps, or structures. You are coming in as the researcher, right? How would you design, and what might that design look like? All right, so we're going to take 5 minutes, about 5 minutes. So go for it.
Yeah, that's good. Yeah, I know. What the short answer would be, why not do exactly what Ricardo or I are doing? Really simple. Deceptive simple interventions. But literally, I know. So the answer to that was question very interesting. How you do research. And all the things that didn't is conditions improvement. All of the actual content is being not stuff that seem to me. It's very much about embedded in.
Ben, do you have the answers?
I made a very brief contribution. We're on here, remember? So we're no, it's fine. Hello, Will. I'm furiously tweeting and communicating.
Good.
And made a little contribution to a very small one to what Leisha and Tim have been saying.
Oh, okay.
But Leisha does a lot of work in low middle income countries, so she will have some good things.
Okay.
I'm just saying to Edilma that you particularly with your
You've got the
your
answers.
work, you know about this, yeah. I think.
Well, I was just thinking the project starts in next year, really long experience.
Time?
1 minute.
1 minute? Okay.
Yeah.
Well, I don't know. We'll see how Edilma wants to play it. I reckon we'll have something to contribute. There we are. Leisha's going to give you some responses.
You are happy?
On the in the conference committee, you are absolutely the low middle income country mental health expert. You are. You are. No. You're the
The way
person
he
who actually
said
does research. Yeah. You are. No, you are. More than anybody else on the committee. Yeah.
And it's so interesting because I'm not really involved in any of
You're definitely forging ahead. I can see that.
Hello, we're going to get started. Glad you were having a good conversation. So let's get feedback from this side of the room. Let's take maybe 2 minutes for feedback from this side of the room. So you had the first question. What would an effective approach to increasing mental health literacy and decreasing stigma in a low middle income country look like? So what were your thoughts?
I'm going to speak for absolutely everyone on this side. We did think that first of all it would be really useful to find out where the stigma lies. So are there particular older people, younger people who have a particularly negative view? And we also thought it was probably important first of all to check out whether the people who would influence views, such as teachers and healthcare professionals themselves, hold stigmatising views, because if you want to change views of kids, you probably need to make sure that the teachers are aligned with that in the first place, so they were kind of thoughts.
Great.
I think you need to ask patients, number one, what they think stigma is. How else will you find out?
One more from this side.
Thank you. We had a lot of ideas. We talked about needing to understand the language of the region and how suffering is communicated in that particular region. That's so important to understand just exactly how is it being expressed in words or in body manifestations like somatization, and to just acknowledge and appreciate that, and not necessarily that we're judging it, but just trying to understand from the perspective of the people that live in that region.
Great.
Should we move to this
Thank you,
side?
Julie. Yes. So this side was looking at the research approach. So what were your thoughts about how you would begin this process?
My colleague and I thought that it would have to start off with deciding which definition you want to use, and then also putting together that conceptual framework that you were talking about, and from that perhaps splitting up what the research was going to look at, whether it was mental health literacy or the stigma reduction or combined. And then from that, deciding on the actual research question, and that would guide the design of the study or the studies.
Okay.
We also thought that it would be important to understand how that particular group define understand or define mental illness amongst themselves, and then we wouldn't impose our Western understanding of mental illness, but we would use their words and their understanding, and then do the research starting from there, and then bring it around to a conclusion in comparison to what we have.
Good, thank you. Others?
One more.
Thank you. We discussed, myself and my colleague, that the researchers need to go into that area and understand the culture, but you really need to involve the local, those mental health service users that are being impacted. You need to involve them in the design. It should be co-design and co-production, really. You need to involve local researchers. That would mean that sometimes, obviously, the research may have to be designed in the local dialect. So you need local researchers that understand the language, that could help with data analysis. And because if it's actually designed in the local people's dialect, and obviously empowering service users, training and educating them to take a lead on that, they will be able to attract more respondents or participants to the researchers. And probably we're also thinking about mixed methods rather than just qualitative.
Right. Very good. Yeah. 1 minute?
Yeah.
Okay. So thank you very much. I wanted you to sort of think about how complicated this is, but also there are ways we can do this. We really can do this. We're pretty smart people, and it's just about looking at what you have and maximizing what's there, but also being way inclusive. And inclusive meaning, if we're doing research in low middle income countries, it's about including the population that we're working with. So just a list of the summary, we have to intervene with multiple audiences, right? So maybe a team of different researchers looking at this from different perspectives, working together. How novel is that? So, working together on different pieces of this. This is huge. So do we have maybe 5 different pods of researchers on the ground in a particular space working on different pieces of this? We're working together on different pieces. We have to include and understand the cultural perspective. We have to use, I think, community-based participatory research throughout, from the beginning. We have to go talk, include, listen to, incorporate people on the ground. We do need to include traditional healers or culture brokers. They're really going to be a strength in a research design. We have to intensify our efforts in schools and with youth, educating our youth early on. We have to target healthcare providers. We are part of the problem. If we're biased or stigmatizing our consumers, we are perpetuating stigma. So we have to really make sure we pay attention to ourselves also. We need to think about this as a long-term issue. We're not just in there for a short period of time. We need to work with people over a longer period of time and look at effectiveness. And as I triple or quadruple start this, your ministers of health in these environments, if you can get them on your side, you really do have more access to resources, and also they can sort of help with policy further down the road with some policy issues that we might need. So in order to increase mental health literacy and decrease stigma, we have to target this from multiple perspectives. Thank you very much.
Well, thank you so much, Edilma. Time for concurrent sessions. Just a reminder to chairs, try to keep to time if you can. Thank you.